Hello there and welcome to this talk on understanding ventilation, brought to you by Atoza. My name is Garth. In this video tutorial, we will be discussing the basic physiology of ventilation and gas exchange. We will look at the breathing circuit. We will also look at the common ventilatory modes used during anesthesia, including spontaneous ventilation, controlled ventilation modes, and then the supported ventilation modes. We'll also be discussing PEEP, what it is, when we use it, why we use it, and how we use it. And then we'll look at lung recruitment maneuvers. There is a second video lecture in this series where we specifically look at the complications during ventilation under anesthesia, so look out for that video and do watch it. Let's start off by looking at some basic physiology. The purpose of ventilation is to oxygenate the venous blood flowing through the lungs and to allow the removal of carbon dioxide from this blood. In the video talk on the circulatory system, we discuss why oxygen is essential for life, and it all comes down to energy generation during aerobic cellular respiration. Let's start off by looking at spontaneous ventilation. So, spontaneous ventilation is negative pressure ventilation, as opposed to the mechanical ventilation we do in anesthesia or intensive care medicine, which is positive pressure ventilation. The lungs themselves are passive in the ventilation cycle. They are housed within a negative pressure chamber, which is the chest or the thorax. At rest, which is the end of normal exhalation, so the end of breathing out, when the system is at rest, the ribs are in a state of slight outward pull, which creates the negative pressure that keeps the lungs open and prevents them from complete emptying or collapse. This is an essential point to understand. At the end of normal exhalation, the lung volume is not zero. The lungs are still held open by the chest wall, and they still hold a volume. This volume is approximately 3 liters in the average adult patient, and it's called the functional residual capacity. The functional residual capacity means that gas exchange between the alveoli and the blood can occur throughout the ventilatory cycle, including during periods of apnea. So if I hold my breath for a short period of time, there's still air in my lungs that's undergoing gas exchange with the blood. During inhalation, the diaphragm pulls downwards and the rib cage pulls upwards and outwards, and this creates a greater negative pressure within the chest cavity, and that negative pressure pulls the lungs outwards and it increases their volume, and as that happens, air is sucked or drawn through the airways down into the lungs. Exhalation is largely a passive process, and that is relaxation of the diaphragm and relaxation of the rib cage, remove the negative pressure and allow air to be exhaled from the lungs out of the airway into the environment. This graphic shows some of the various volumes of the ventilatory cycle. The tidal volume is the volume of each normal breath, and it's around 6 to 8 mils per kilogram. It is possible to take a larger breath than normal. This is called the inspiratory reserve volume, and if we add the inspiratory reserve volume to the normal tidal volume, we have the inspiratory capacity. So that's the maximum inspiratory breath that we can take. It is also possible to exhale deeper than normal, but one can never exhale to a zero volume. There is always a residual volume within the lungs, and this is called the lung residual volume. The volume that one can exhale below our normal resting volume is the expiratory reserve volume. And the expiratory reserve volume added to the residual volume is what makes up our functional residual capacity, which is the volume of the lungs at apnea or at the end of normal exhalation. The functional residual capacity means that gas exchange between the alveoli and the blood can occur throughout the ventilatory cycle, including during periods of apnea. A vital capacity breath is a breath from maximal exhalation to maximal inhalation. So one can breathe out maximally and then breathe in maximally. That's called a vital capacity breath, and this can be used to aid pre-oxygenation in anesthesia. If we get our patients to do 3 to 5 vital capacity breaths on an inspired oxygen concentration of 90%, then we can get our expired or alveolar oxygen concentration close to 90%. So that's the ventilatory cycle in terms of lung volumes. Next, let's look at the control of ventilation. Ventilation is controlled in the brainstem, which receives inputs from many receptors, including peripheral receptors, central receptors, and the respiratory center in the brainstem is itself extremely sensitive to carbon dioxide levels. Carbon dioxide is the main driver of ventilation. Oxygen also has an effect on the control of ventilation via peripheral chemoreceptors, but this only comes into play when oxygen levels drop below around 8 kPa, which corresponds to an oxygen saturation of roughly 90%. The acid-base status of the body also drives ventilations, but these effects are slow and they normally only occur in severe acid-base abnormalities. In anesthesia, it's important to understand the concept of a respiratory depressant. A respiratory depressant is a drug that reduces the sensitivity of the brainstem to carbon dioxide levels. In other words, ventilation is only triggered when the carbon dioxide levels are much higher than normal. And we see this commonly in anesthesia. If we have a spontaneously breathing patient, that patient breathes spontaneously with a higher than normal carbon dioxide level, and that is because of the respiratory depressant effect of our anesthetic drugs. Some of our drugs can also reduce the hypoxic drive of ventilation, which means that even in the face of hypoxemia, with saturations less than 90% or a partial pressure of oxygen of less than 8 kPa, ventilation may not be triggered by the hypoxemia. And this places patients at added risk of having a hypoxic event if not managed or monitored appropriately. So that's the control of ventilation in a nutshell. Now let's examine the lung, which is the organ of ventilation and the place where gas exchange occurs. The interface where air meets blood in the lungs is at the level of the alveoli. This is where gas exchange takes place. Oxygen from the alveoli enters the blood, and carbon dioxide from the blood enters the alveoli. The diffusion of gases across the alveoli can be affected by disease states, such as inflammation of the lung tissue or fluid within the alveoli themselves. If this occurs, the blood passing through the alveoli may not be adequately oxygenated or may not be adequately cleared of carbon dioxide. Airflow and blood flow within the lungs are not equal in all areas or zones of the lungs. Blood tends to flow to the lower areas of the lungs due to the gravitational effects on flow, while air tends to flow more freely in the upper aspects of the lungs due to the lower resistance in these areas. So blood flow and airflow are often not equal or not matched within the various areas of the lungs. And this creates three broad areas within the lungs. There are areas of high ventilation with relatively lower blood flow, such as in the apex of the lungs. There are areas of matched ventilation and blood flow. This is normally in the mid-zones of the lungs. And there are areas of relatively low ventilation and higher blood flow, which tends to be in the bases or the dependent areas of the lungs if the patient is supine for a long time. The term describing this phenomenon is ventilation perfusion mismatch, and this is an important building block for further understanding of ventilation in anesthesia and in ICU. Two other important terms for us to understand are dead space and shunt. Firstly, let's look at dead space. Dead space refers to the ventilated parts of the respiratory tree that cannot take place in gas exchange, and it includes the large airway passages because they have no alveoli, and so they cannot take part in gas exchange, and this is approximately 2 mL per kilogram in volume, or 150 mL in the average adult. We refer to this type of dead space as anatomical dead space. Then there are also alveoli that are ventilated but receive no or relatively poor blood flow, and they also contribute to dead space. This dead space is called physiological dead space, and it varies from patient to patient. So, in summary, dead space is the portion of each tidal volume that does not contribute to gas exchange within the lung. Next, let's move on to shunt. A shunt occurs when deoxygenated blood, which is venous blood, passes through the lungs and re-enters the systemic circulation without becoming oxygenated. And there are a few causes of shunt. Blood flowing through the lungs in the pulmonary circulation can flow past alveoli that are not ventilated or have relatively poor ventilation for the degree of blood flow, and so that blood is not oxygenated adequately. And an example of this could be the bases of the lungs. It could also be alveoli which are filled with fluid or infection, not aerated, and it can also be parts of the lungs that have undergone collapse and are not ventilated, but blood still flows through those parts of the lungs. The second cause of shunt is the blood that flows through the lungs in the bronchial circulation. So not the pulmonary circulation, the bronchial circulation. And this blood takes nutrients to the lungs, but it does not become oxygenated before it returns to the systemic circulation. And so it contributes to shunt. And then there are certain cardiac abnormalities that are usually seen in children, but may be present in adults that can result in right to left shunting within the heart and deoxygenated blood mixing with oxygenated blood. So those are the causes of shunt. Now that we have covered some basics of respiratory physiology, let's look at the causes or types of hypoxemia. Remember that hypoxemia refers to a low oxygen content in the blood. In other words, low oxygen saturations. The causes of hypoxemia are a low alveolar oxygen content, which can be because the patient is breathing air that has got a low oxygen content itself. We call that a hypoxic mixture, or it can be due to hypoventilation of the alveoli. The next cause of hypoxemia is a diffusion abnormality. That means that oxygen cannot move from the alveoli into the blood. And this can be because of diseases of the alveoli or interstitium of the lung that result in fluid or inflammation that increases the barrier that oxygen has to pass through to get into the blood. And then the third cause of hypoxemia is shunt. Next, let's look at the causes of hypercapnia. That is a high carbon dioxide level. So as I've already said, respiratory depressing drugs increase the carbon dioxide level at which spontaneous ventilation is triggered. And so hypercapnia can be because of respiratory depressant drugs. Another cause of hypercapnia is hypoventilation or low minute ventilation, either because of a low respiratory rate or a low tidal volume. It's important to remember that in situations where the tidal volume is low, the anatomical dead space remains unchanged and takes up a higher proportion of each tidal volume. And so the actual alveolar ventilation is disproportionately decreased. Another cause of hypercapnia is depletion of the carbon dioxide absorber in the circle system of our anesthetic workstation. And then hypermetabolic states can also cause hypercapnia. And these include sepsis, trauma, malignant hypothermia, and there are a few other worrying hypermetabolic states. Right then, so let's now move on to mechanical ventilation. Mechanical ventilation is positive pressure ventilation, meaning that air is blown into the lungs under pressure by the ventilator. In order for this to occur, there need to be some control ventilator settings. Firstly, there needs to be something to initiate the breath. We call this the trigger. Usually the trigger is time. We can adjust this by adjusting the respiratory rate. So if we set a respiratory rate of 12 breaths every minute, then every 5 seconds the ventilator will trigger inspiration. The trigger can also be based on patient effort. This is usually inspiratory flow, and so the ventilator can detect when the patient makes a ventilatory effort by generating a negative inspiratory flow, and then a positive pressure breath can be triggered on the ventilator. And we can adjust the sensitivities of this flow trigger. Next, we need to set a target for the inspiratory phase of the ventilator, and we call this the limit. We can have pressure-limited breaths where we set a pressure limit for each breath, and this has the benefit of preventing barotrauma because the pressure won't go above the limit that we set, but it may still result in volume trauma to the lungs if the volume delivered is too large. It can also result in hypoventilation if the set pressure delivers an inadequate volume. We can also have a volume-limited breath where we set the volume that we want the ventilator to deliver with each breath, and this has the benefit of preventing volume-related trauma to the lungs, but it may still result in pressure-related trauma depending on the compliance of the lungs. So we have set the trigger and we have set the limit. Then we need to set something to initiate the change from inspiration to expiration, and we call this the cycle. The cycling between inspiration and expiration can be time-based, it can be pressure-based, or it can be volume-based. Different ventilator modes, and sometimes even different ventilator makes displaying the same modes, can have different triggers, limits, and cycles. Understanding these aspects of the ventilator are essential for understanding more complex modes of ventilation. and it might sound quite intimidating at this learning level. But now we'll go through the more common, simpler modes of ventilation, and you'll realize how easy it is to understand the trigger, the limit, and the cycle when thinking about these ventilatory modes. Let's begin with volume-controlled ventilation, which I think should be the default ventilatory mode for the learning anaesthetist. This is a form of mandatory ventilation by the ventilator. We set the volume of each breath, and we set the number of breaths that we are going to deliver in each minute, and we can set the cycling time between inspiration and expiration. And then each of these breaths is delivered by the ventilator, irrespective of the patient's spontaneous breathing efforts. That's why we call it a mandatory ventilatory mode. So as the operator, we can adjust the respiratory rate. A normal respiratory rate in an adult patient will be somewhere between 12 to 16 breaths per minute. We can set the tidal volume, and I recommend using a tidal volume of 6 mils per kilogram to avoid volume trauma to the patient. And we can set the inspiratory-expiratory ratio. This is how we set the cycling time of the ventilator. So the normal setting for an IE ratio is 1 to 2. That means that expiration is twice as long as inspiration. If we look at a respiratory rate of 10 breaths per minute, that means every 6 seconds we are going to deliver an inspiratory breath. With an IE ratio of 1 to 2, our inspiratory time is going to be 2 seconds, and our expiratory time is going to be 4 seconds. That is what the IE ratio is telling us. We can also set the PEEP on this ventilatory mode, and we'll look at PEEP a little bit later in this video lecture. On some ventilators, one can add an inspiratory pause. That means that at the end of inspiration, there is a slight pause where that volume is held within the lungs before exhalation occurs. And it's not normally needed for normal ventilation, but there are some anesthetic workstations that default to having an inspiratory pause, and we'll see that in managing auto PEEP and in managing bronchospasm, which we'll discuss in the next video on ventilation, it's necessary to remove the inspiratory pause. So it is worthwhile knowing about the inspiratory pause and looking on your anesthetic workstation whether the inspiratory pause is defaulted on. As I've said, volume-controlled ventilation should be the mode that the trainee anaesthetist uses, because it's most likely going to protect against missed hypoventilation. Each volume is going to be delivered irrespective of what pressure is generated, provided obviously that pressure is below the pressure limit that's set on the ventilator. So in our ventilatory settings, there's a limit. It's normally set at 40 centimeters of water, and when an inspiratory volume generates that pressure, the machine cuts off and it doesn't deliver any volume further than that. So there is some protection against barotrauma in volume-controlled ventilation, but one can still have pressures of 39 or 38 centimeters of water, which could be doing harm to the lungs, and those might go undetected. One can make this mode a little bit safer by decreasing your pressure limit from 40 centimeters of water down to 35 centimeters of water or 30 centimeters of water, so that your attention is drawn to the high pressure earlier in the process rather than later. The other problem with volume-controlled ventilation is it's probably less physiological than pressure-controlled ventilation. And the actual physics and physiological explanation of this is not essential.
The problem is that volume-controlled ventilation is a constant flow mode of ventilation. That means that the inspiratory flow is the same at the beginning of inspiration, the middle of inspiration, and the end of inspiration. But the compliance of the lungs changes with inspiration. The compliance is not the same at the beginning of inspiration, the middle, and the end of inspiration. And what this results in is higher peak airway pressures per volume delivered compared to a pressure-controlled mode of ventilation.
Next, let's move on to pressure-controlled ventilation. So this is also a form of mandatory ventilation by the ventilator, which means the ventilator is going to deliver the breaths irrespective of the patient's spontaneous breathing efforts. We can set the respiratory rate again, and we can also set the cycling time by adjusting the IE ratios again. The main variable that we can adjust is the inspired pressure, which is the limit of each breath. We can also set a PEEP, and we'll again discuss PEEP a bit later in this video. So the pressure of each breath that we deliver is constant, but the volume of air delivered with each breath is variable, and it changes depending on the compliance of the lungs at that time. And the compliance may be affected by numerous things. If there are spontaneous breathing efforts of the patient, so the patient is actually trying to breathe out just as the ventilator breathes in, that's going to affect the compliance of that breath. If one is performing laparoscopic surgery and we've inflated the peritoneum with lots of carbon dioxide and the peritoneum is under pressure, that's going to have an effect on the lung compliance. There are other things that can affect compliance too, such as secretions in the endotracheal tube or a kinked endotracheal tube. And so from this we can see that with variable compliance, there is a risk of hypoventilation with pressure-controlled ventilation. How can we protect against this? Well, just as we can adjust our alarm limits in volume-controlled ventilation, we can adjust our alarm limits in pressure-controlled ventilation. And the alarm that we want to adjust here is the minute ventilation alarm. And we want to make sure that the lower limit alarm is set at an adequate value. So for an adult patient such as myself, my normal minute ventilation is probably 5 liters per minute. It would be very inappropriate to have a low level alarm at 2 liters per minute, because I'm going to hyperventilate significantly before that alarm goes off. So if you were performing pressure-controlled ventilation during my anesthetic, perhaps then you should set the minute ventilation alarm at 4.5 liters a minute. Then if there is a change in compliance, the alarm will pick up that hypoventilation early in the problem and you can correct it. From a physics or physiology point of view, pressure-controlled ventilation is usually able to deliver the same volume as volume-controlled ventilation, but at a lower peak airway pressure. And this is because it's more physiological ventilatory mode. It is a constant pressure, variable flow ventilatory mode. And this is different from volume-controlled ventilation, which we said was a constant flow ventilatory mode. There's a new mode of ventilation on some of the modern anesthetic workstations, and this is pressure-controlled, volume-guaranteed ventilation. And this ventilatory mode offers the benefits of both volume-controlled ventilation and pressure-controlled ventilation. It's essentially a pressure-controlled mode that is adjusting in real time to achieve a targeted volume with each breath. And so we get constant pressure breaths, variable flow breaths, but achieving a desired tidal volume with each breath. And this is what I default to in my anesthetic practice. So let's move away from mandatory ventilatory modes now and discuss supported breaths. A supported breath is a breath that is initiated by the patient. The trigger of the breath is therefore generated by the patient, and it's usually an inspiratory flow from a spontaneous respiratory effort. So the patient makes some effort to suck air into their lungs. The ventilator then detects this inspiratory flow and it supports the breath with a set positive pressure or a set volume. The limit of the breath is the pressure or the volume that we add to each supported breath. So the anesthesia workstations that I work with have a few support ventilatory modes. So the first is PSV, or pressure support ventilation. Here, the variables that the operator can control are the flow trigger. So how much air does the patient have to suck in during their respiratory effort to trigger the ventilator to support the breath? Normally, the workstation defaults to a flow trigger of 2 liters per minute, but we can adjust this. We can make it easier for the patient to trigger a breath by reducing that to 1 liter a minute or half a liter per minute, and then smaller patient efforts will trigger a supported breath. I don't recommend ever increasing it above 2 liters per minute though, because that just means the patient has to make more effort to trigger a breath. The operator can also adjust the limit, which in this mode is the pressure support added to each breath. So we can set that pressure support. I normally don't go below a pressure support of 6 centimeters of water because I want to make sure that the ventilator is overcoming the resistance of the breathing circuit and the breathing tube, and the patient isn't having to work against those resistances. But while I'm establishing pressure support ventilation, I may go as high as 15 centimeters of water until the patient is taking adequately strong inspiratory breaths by themselves. We can also adjust the PEEP as we can in all the other ventilatory modes, and then we can set a backup minimum respiratory rate, which is a spontaneous respiratory rate below which the ventilator will activate a backup mode or an apnea mode of ventilation. So pressure support ventilation is a mode that I often use when the patient has a supraglottic airway device in situ, such as a laryngeal mask airway. And I often also use this during emergence from general anesthesia, where the patient has an endotracheal tube in situ and they've started to breathe spontaneously towards the end of the anesthetic. Then I use a pressure support ventilation. So the next mode of ventilation that we have available on most anesthesia workstations is a combination of mandatory ventilation and support ventilation. And this is called SIMV, and it stands for Synchronized Intermittent Mandatory Ventilation. This mode of ventilation was originally created to assist with weaning of ventilated patients in the ICU setting. In this mode, the ventilator tries to synchronize the two forms of breaths. That's the spontaneous breaths and the mandatory breaths, so that breathing is coordinated and smooth. And there are numerous combinations that one can use in synchronized intermittent mandatory ventilation. We can have volume-controlled mandatory breaths with pressure-supported spontaneous breaths. We can have volume-controlled mandatory breaths with volume-supported spontaneous breaths. We can have pressure-controlled mandatory breaths with pressure-supported spontaneous breaths. So there are a number of different combinations. And I use this mode of ventilation, SIMV, when patients start to make spontaneous respiratory efforts and when muscle relaxation is no longer required for the surgery. In this mode of ventilation, we can adjust the trigger for the supported breath just like we can do in pressure support ventilation to make it initially easier for the patient to trigger the spontaneous supported breath. So I often go down as low as 0.5 liters per minute initially until spontaneous breaths are being triggered regularly, and then I increase that trigger again to 1 or 1.5 or 2 liters per minute. One can also adjust the support given to each spontaneous breath. So again, initially, when the respiratory efforts of the patient might be quite weak, one can have a higher support level of, say, 15 centimeters of water. But then as the patient's respiratory effort improves and the tidal volumes improve, we can bring the support down to 6 or 8 centimeters of water support added to each spontaneous breath. One can also change the number of mandatory breaths per minute. So again, initially, while the patient is still establishing regular spontaneous ventilation, we can have a higher mandatory respiratory rate of, say, 10 or 12 breaths per minute. But then once the patient is breathing more regularly, we can bring the mandatory respiratory rate down to 6 or 8 breaths per minute. And then I frequently transition from SIMV onto full pressure support ventilation. That is spontaneous breaths that are supported by the ventilator with no mandatory breaths. And I do this towards the end of the surgery, during emergence, and just prior to extubation of the patient. The last mode of ventilation during anesthesia can be spontaneous ventilation without any support at all. And this mode is easily achieved on the anesthesia workstation by selecting manual or spontaneous breathing on the ventilator. In this scenario, the patient breathes spontaneously without any support. One can manually add PEEP to the patient's breaths by adjusting the pressure on the adjustable pressure release valve. And I normally have a minimum pressure of about 5 centimeters of water, so one can adjust the valve to try to achieve that pressure. It's acceptable to have patients breathing spontaneously under anesthesia when they have a supraglottic airway in place. I don't ever have patients breathing spontaneously intraoperatively through endotracheal tubes because the endotracheal tube is long and thin. It offers a resistance to the patient's inspiratory efforts, and so I always have a pressure support mode of ventilation as my minimum ventilatory mode when there's an endotracheal tube in place. So perhaps the only time when I would have a patient breathing spontaneously through an endotracheal tube is really immediately before extubation, when I turn the ventilator off and I put the patient onto a man-spont breathing mode. And here I would adjust the APL valve to a PEEP of 5 or 10 centimeters of water. And at this point, I would probably deliver a manual positive pressure breath to the patient so that I extubate them with their lungs full, so that their first ventilatory movement post-extubation is exhalation, so that they can cough out and clear any secretions that may be on the vocal cords. So to summarize all of that, in intubated patients, I normally start on a volume-controlled ventilatory mode. Once paralysis is no longer needed and spontaneous ventilatory efforts have begun, and I can see that on the ventilatory graphics, I then change to an SIMV mode. And then once reversal is given and the patient's respiratory effort is good, I then change to a pressure support ventilatory mode. And then I slowly wean down the pressure support to a driving pressure of about 6 centimeters of water. And then just prior to extubation, I either extubate directly off pressure support ventilation, which I'm comfortable doing, or prior to the extubation, one can place the patient on spontaneous breaths and adjust the APL valve so that one still delivers a PEEP of at least 5 to 10 centimeters of water, or so that one can deliver a positive pressure breath just prior to extubation, which is what is recommended by the extubation guidelines from the Difficult Airway Society. In patients that have got a supraglottic airway, my ventilatory mode depends on the nature of the surgery and the anesthetic that the patients have received. Often in my style of anesthesia, these patients are apneic post-insertion of the laryngeal mask airway, and so they need volume-controlled ventilation. As the surgery progresses, I find it quite useful to get the patients to breathe spontaneously, and so when I see signs of respiratory effort again, I start with an SIMV mode, and then I transition to a pressure support ventilatory mode. In my book, ventilating patients with an LMA still requires the application of PEEP, and I try to use PEEP in all of these patients. I do sometimes come across problems where if I do use PEEP, there's a leak from the LMA, and for short cases then I may turn the PEEP off. But if I'm unable to apply PEEP and it's a slightly longer case, then I would rather remove the LMA and intubate and ventilate the patient with PEEP, because what I don't want is de-recruitment and collapse of the lungs. Okay, so we've mentioned PEEP now quite often, and it's time that we tackle this rather controversial and difficult topic. So if you remember from the above, we said that at rest, at the end of normal exhalation, the lungs are held in an open state by the pulling forces of the chest wall. So the chest wall wants to expand outwards, and that's what holds the lungs in an open state, and that open state has a volume of around 3 liters, and it's called the functional residual capacity. So under anesthesia, muscle tone is significantly reduced. Even if patients are not paralyzed, the anesthetic drugs reduce muscle tone, and so the forces holding the lungs open are reduced, and the lungs tend to be smaller and to hold a lower volume, and there are areas of the lungs that collapse completely. And these areas of collapsed lungs can have significant detrimental effects. Firstly, the forces required to reopen collapsed segments of lung are much greater than normal. Again, if we go back to the analogy of blowing up a balloon, when the balloon is collapsed, those initial forces required to open the balloon are much higher than when the balloon is in a mid-state of expansion. And so the constant reopening and collapsing of these segments of the lungs can cause damage to the lungs because the forces are so great across that segment every time it opens and collapses. And this damage from repeated atelectasis is called atelect trauma. So trauma to the lungs caused by repeated atelectasis. Because the collapsed areas of the lung are more resistant to airflow, so we've just said it's far more difficult to get air into those collapsed lungs. Because those segments tend to resist airflow, the air that we blow into the lungs under positive pressure tends not to go to those areas, and it goes to other areas of the lung. So the same volume of air that we blow into the lungs is actually now going into a smaller volume of lung. And so those remaining volumes of lungs can actually be hyperinflated, and they can have damage from overinflation. The next problem with collapsed segments of lungs is that because the air doesn't want to go into those collapsed areas because of the force required to open them up, you have relative hypoventilation or no ventilation of those collapsed areas. But that collapsed segment may still receive blood flow. And so we know what we call an area of lung that receives blood but no ventilation. We call that a shunt. And so the blood that goes through that part of the lung may re-enter the systemic circulation still deoxygenated, and it will contribute to shunt and to hypoxemia. So those are some of the problems with collapse of alveoli or segments of the lung. So PEEP is the application of airway pressure at the end of exhalation so that the patient is not allowed to exhale to a pressure of 0. As the patient breathes in under positive pressure, the pressure in the lungs increases, And then when exhalation is allowed, that pressure now decreases as air moves out of the lungs, but PEEP prevents that pressure from going to zero. And so the lungs are held in a more open state. They're held with some pressure in them and they're held open. And that helps to prevent collapse. It helps to reduce the shear stress. So as I've said, the continued opening and closing of alveoli causes shear stress across those alveoli membranes, and it helps to reduce shunt. It's important to remember though that even when PEEP is applied, each inspiration and expiration is complete. The volume of air that goes into the lungs is the same volume of air that exits the lungs. Okay, there's not air trapping. It's not like we are with each breath adding more and more air to the system. What goes in comes out. It's just that the lungs are held in a positive pressure state. So where the controversy comes in is what PEEP level is needed to prevent atelectasis and to prevent damage to the lungs. And the bottom line is that it's very variable, it's very patient specific or scenario specific, and it's quite difficult to find out what the optimal PEEP level is. And if one looks at some of the ICU studies on trying to work out what the best PEEP level is, they have to go to extreme measures of taking patients for CT scans to try assess what the lung volume is with different PEEP settings. That's how difficult it is to ascertain the optimal PEEP level. But for the training anaesthetists doing relatively safe standard anesthesias, I would recommend a minimum PEEP level of 5 centimeters of water, and in the pregnant or obese patient or during laparoscopic surgery, I would increase that PEEP level to 10 centimeters of water. Okay, so that's sort of a generic approach to PEEP. PEEP is best applied to lungs that are already in an open state. Okay, so we want the lungs to be open, and then we apply the PEEP and we prevent collapse from occurring. That's where PEEP works best. So what do we do in situations where collapse has already occurred? And collapse of lungs actually occurs really easily. Some might even argue during a normal induction and intubation of a patient, there is already alveolar or segmental collapse that has occurred in those patients.
Some other examples of where atelectasis or derecruitment may occur are if we struggle with our airway management and there are periods of hypoventilation or apnea during airway management. Also, if there are secretions in the airway or in the endotracheal tube and we suction down the endotracheal tube with a soft suction catheter, this will result in collapse of parts of the lungs. Collapse also frequently occurs during abdominal surgery, especially laparoscopic abdominal surgery, where the pneumoperitoneum that's created compresses the diaphragm upwards and causes basal atelectasis. Overweight patients are very prone to atelectasis during general anesthesia. And so there are numerous examples where this occurs. The clinical technique of re-expanding collapsed or derecruited lungs or segments of lungs or alveoli is called a lung recruitment maneuver. Before I describe the technique of the lung recruitment maneuver I use during anesthesia, let's first look at how we detect atelectasis or derecruitment during anesthesia. The first feature and most clinically pressing feature of atelectasis is the development of hypoxemia from shunt. The clinical approach to hypoxemia is discussed in the next video on ventilation, but atelectasis is an important cause.
There are other features of atelectasis too on our ventilator graphics. We can see poor compliance on our compliance waveform, or we can actually just see that we are delivering a small tidal volume for the pressure that we are giving to the patient. Many anesthetic workstations now have ventilator graphics that will show lung compliance graphically or numerically. And it's also possible to watch these graphics to note negative or positive changes during events or interventions in theatre. So if your ventilator does have an option where you can see these graphics, I would recommend displaying it on the screen. It might not be immediately relevant to you while you're learning anesthesia, but the more you watch these graphics, the more you'll benefit from building up your own data bank of what they mean. So my method for employing lung recruitment maneuvers, if I suspect atelectasis, or if there's hypoxemia or a higher than normal oxygen requirement to maintain our oxygen saturations, I then look at the shape of the compliance curve, and I start by saving a copy of the compliance curve. So ventilators that show a compliance curve often allow you to save a reference loop, or I write down the actual values, the numerical values. So what is my pressure and what is my volume? So say, for example, I'm delivering a peak inspiratory pressure of 32 centimeters of water, and I'm delivering a volume of 350 mils of air. That will be my reference point. I then increase the PEEP to 10 centimeters of water, and I deliver 10 high volume breaths of 10 mils per kilogram to try and open up the collapsed alveoli. So I can do that either by delivering manual breaths with the bag in the circuit, or I can set my ventilator to deliver higher than normal tidal volumes. So in a patient like myself, where my ideal body weight is probably 80 kilograms, I would deliver 800 mil breaths to a patient like me, and I would do 10 of those breaths at the higher PEEP setting to try and open up the collapsed alveoli. Following that, I will then decrease the tidal volume again to 6 mils per kilogram. And then I can review the volume pressure ratio that I've attained on the normal screen monitors or on the compliance curve. And what I'm hoping to see now is that for my same, which was 32 centimeters of water, I'm achieving a higher volume. Say now I'm achieving 450 mils volume instead of 350 mils. So that tells me that the compliance has improved. That would be in a pressure mode. If I'm in a volume mode of ventilation, that 350 mil volume was generating a peak pressure of 32. Now, when we deliver a volume of 350, our peak pressure is 22. So we've seen a decrease in the pressure required to deliver that same volume, and that means our compliance has improved. What we should also see is an improvement in our oxygen saturations, and we should be able to decrease our inspired oxygen concentration to achieve those saturations. So that would represent a successful recruitment maneuver. If the recruitment maneuver has been unsuccessful, then one can repeat it again at a higher PEEP. So instead of putting the PEEP at 10 centimeters of water, one can put the PEEP up to 15 centimeters of water and repeat the maneuver again with 10 large volume breaths, and then see if that makes a difference to the compliance and the oxygenation. And if it is successful, then one can slowly decrease the PEEP from 15 centimeters to 14 centimeters to 13 centimeters to 12 centimeters to try find the optimal PEEP, the lowest PEEP level that maintains our good compliance and good oxygenation. I think at a learning anesthetist level, there shouldn't be too many circumstances where you require a PEEP of 15 centimeters of water for the whole duration of your anesthetic. I think that those cases where that's necessary are probably beyond the scope of your practice, and certainly then you would want to seek help from one of the senior anesthetists in your department. There are some negative consequences of applying PEEP. So when we apply PEEP, we maintain a positive pressure within the thorax throughout the respiratory cycle. And that can have some cardiovascular effects. It can reduce venous return, which can affect your preload and your cardiac output. It can affect right ventricular function. So in patients that have got poor or failing right ventricles, the application of high PEEP pressures can be detrimental for them. It can increase venous congestion in the head and neck areas. So if one is doing neurosurgery or thyroid surgery or other head and neck surgery, one could have increased intracranial pressure and increased bleeding. It can also increase your intraocular pressure. So in patients with a perforated globe, that wouldn't be ideal. So there are some negative consequences of PEEP.
Before finishing off the use of intraoperative PEEP and intraoperative lung recruitment maneuvers, I just want to show you this slide that I've created to show the two extremes of PEEP and airway pressures. So this is obviously a volume pressure curve of inspiration. And if we start in the bottom left corner where the volumes are 0 and the PEEP is 0, what we can see is that initially a substantial pressure is required to generate quite a small volume increase in the lungs. And this is because of the forces or pressure required to open collapsed alveoli. And in this process of repeated collapse and re-expansion, one can cause atelic trauma. Then in the middle part of the curve, one can see the curve is almost linear, and a relatively small increase in pressure results in a substantial increase in volume. So this is where our lung compliance is at its best. And if we look at the diagram on the right, where I've shown the ideal circumstance, this is where there's good blood flow and the alveoli are held in an open state. If we move towards the top right corner of the diagram now, what we can see is flattening out of our compliance curve or flattening out of our volume pressure curve. And the diagram on the right shows you that at these pressures, our alveoli are over distended and our blood flow to those alveoli is decreased because of compression of the capillaries and the small blood vessels. And so we actually generate perfusion mismatch. So this diagram shows us that we don't want under distension or low PEEP because of the collapse re-expansion trauma that occurs in that situation. But we also don't want over distension from excessive tidal volumes or pressure that then decrease capillary blood flow to the alveoli. And so where we want to be is in the sweet spot, which is the linear aspect of the curve. And so then this diagram shows that same compliance curve, the black curve, where there's no PEEP and also where there's over distension of the alveoli at high volumes or high pressures. And what we've done in this situation is we've applied PEEP, and so we can see the green curve is shifted to the right because we are not starting at a pressure of 0 because of our PEEP. We are starting at a higher pressure, and so our volume pressure curve is immediately more linear, and we avoid the collapse re-expansion trauma at the beginning of inspiration. And then also by limiting our peak airway pressure, we have prevented the flattening out of the curve in the top right corner. And so we are reducing the over distension effect on the alveoli that results in ventilation perfusion mismatch.
So now we've covered lung recruitment maneuvers intraoperatively. De-recruitment of the lungs or collapse of the lungs can also occur at extubation. And this can be because of periods of hypoventilation post-extubation. It can be because patients are perhaps overly sedated still at extubation and they've got a poor respiratory effort, a poor cough, and it can be because of a poor extubation technique where there's still secretions in the airway or there's aspiration of saliva or secretions into the trachea at extubation, and those affect ventilation. So it is sometimes necessary to perform lung recruitment maneuvers in the post-anesthetic care unit or the recovery room. So in the awake patient, the easiest is to encourage the patient to do deep breathing exercises and especially to do vital capacity breaths. Again, in an awake cooperative patient, we can ask the patient to do a Valsalva maneuver. So we ask the patient to block their mouth and their nose with their hand and then to blow out with pressure against a closed mouth and a closed nose. And that can help to open the lungs. We can also get a non-sterile glove and we can ask the patient to blow into that glove. That can help to expand the lungs. Coughing can also help recruit the lungs. Getting the patient to sit upright or sit in a semi-Fowler's position can help to recruit the lungs. And then physiotherapy on the chest can also recruit the lungs. If you're working in a unit where they have a Mapleson circuit in the recovery room, or perhaps even an ambu bag that has got a PEEP valve attached to it, one can apply external PEEP to the patient. You just have to counsel them and tell them what you're doing, and then apply 10 or 15 centimeters of PEEP with your circuit or your ambu bag and get the patient to breathe against that resistance for a few minutes, and that might help to recruit the lungs. So the ideal is to try to wake up patients in a way that they don't de-recruit, but sometimes that isn't possible, and then we have to have ways of opening up those lungs in the recovery room. And applying oxygen to these patients, or supplemental oxygen, is really just a way of painting over the cracks in the wall or painting over the problem. So if there is atelectasis, there will be shunt, and so by delivering more oxygen into the lungs, one can overcome certain degrees of shunt, and then the picture might look better on the monitor, but one hasn't actually corrected the problem. So in those situations, one really wants to do recruitment maneuvers, and I certainly try not to send anyone to the ward with more than 40% oxygen face mask in place. And if they do go to the ward on oxygen, in my setting, I phone one of the physiotherapists and I ask them to see the patient quite urgently and to start with mobilization and chest physio to help open up collapsed segments of the lung. But I certainly don't like sending patients to the ward on 60% oxygen or more, because then one is really covering over a more significant problem that one should try to correct before discharging the patient from the recovery room. Right, so let's just examine how to prevent acute lung injury during anesthesia. I've already mentioned some of the terms in this talk. You may have picked up on them, but let's just go through them in a bit more detail. So there are a few mechanisms of lung injury during anesthesia. Barotrauma is when we apply pressure to the lungs that is too high or unsafe. And ideally, we want to aim for the lowest airway pressures during inspiration possible. And what we normally see in healthy lungs, that with a PEEP of about 5 centimeters of water, a peak airway pressure of between 15 and 20 centimeters of water is kind of the norm in healthy lungs. As soon as our peak airway pressure becomes more than 30 centimeters of water, there is a risk of pressure trauma or barotrauma to the lungs. And one then has to assess the patient carefully for why that pressure is increased, and we will go into that in the next video, and to try to correct that situation. The next form of damage to the lungs can be overexpansion of the lungs, so volume-related trauma or volutrauma. And here the ideal is to aim for a tidal volume of 6 mils per kilogram of the ideal body weight. And if we do that, the chances of volume trauma to the lungs are small. We can also have oxygen-induced lung injury. And this is because excess oxygen can result in oxygen-free radicals in the lungs, which can damage the tissue itself. So we want to use the lowest inspired oxygen concentration to achieve saturations above 94%. In adults, we don't normally go below an inspired oxygen concentration of 40% in theatre, because we do want some element of a safety backup. Then we've also mentioned atelectasis-induced lung injury. And so we want to prevent injury that's caused by repeated collapse and expansion of the lungs, where the forces and the shear forces across the alveoli are much greater than normal. And the last way of preventing lung injury is just by maintaining our sterile technique and remembering that we don't want contaminated foreign material to go down into the lungs. So that includes saliva from our airway, it includes vomitus from the stomach with a high acidity or particulate matter. And then we also don't want to introduce hospital pathogens into the lungs. So you don't want to put a dirty endotracheal tube that's been on the patient's bedding, or you've dropped on the floor or something ridiculous like that. You don't want to put that into the patient's airway. Okay, so then to wrap up this first video talk on understanding ventilation, we're going to look at the circle breathing circuit, and we're covering it in this section because a number of the complications or problems during ventilation can relate to the circle breathing system. So almost all modern general anesthesia involves the circle system. The primary advantage of the circle system is lower gas usage. That's lower volatile consumption, lower oxygen usage, and lower air usage. And this is achieved by the patient rebreathing the same gases within the circle system over and over again. And it's almost like breathing air in and out of a brown paper bag, like in this picture. The problem is, though, that as the person in this picture rebreathes the same air from the paper bag, the oxygen in the bag decreases and the carbon dioxide in the bag increases. So we need to overcome that. And we can overcome it by adding some carbon dioxide absorbent granules that are called soda lime, and then also by adding a trickle of extra oxygen to the bag via an extra pipe coming in from the side. The other problem is that the bag tends to empty with time because of leaks around the join between the mouth and the bag, and perhaps there are other little tears in the bag, and so there are constant leaks from the bag, and it slowly gets smaller and smaller. And so we need to add some extra air into the bag or into the system to keep the bag full. And we can add that together with the extra oxygen in the fresh gas pipe that's being added to this brown bag. So if we do this, if we add extra fresh gas flow and we have carbon dioxide absorbing granules in the brown paper bag, then this man in this picture can rebreathe from this bag for a very, very long period of time. And this is exactly how the circle system works. So for it to work in the anesthetic scenario, though, we do have to have a few extra components. We need a way of delivering our volatile anesthetic gases into the system. And we do this by adding the volatile gases to the fresh gas flow of oxygen and air. So that's the perfect way of delivering volatiles into the system.
So how do we get from a patient rebreathing air in a brown paper bag to the actual circle system we use in anesthesia? Well, the first step is to actually introduce a circle of breathing tubing and to move the bag away from the patient's mouth. As you can see in this image, the brown paper bag has been replaced with the green reservoir bag of the anesthetic workstation. The next step is to again add our carbon dioxide absorbent into the system, and we do that by having a soda lime canister in the circle system. And then in our circle system, we want airflow to be unidirectional, in that the air exhaled by the patient moves only towards the carbon dioxide absorber and is cleared of carbon dioxide. And so we have to add inspiratory and expiratory valves to our circle system. We, of course, still have our fresh gas flow going through the vaporizer into the circle system to replenish depleted oxygen levels, to compensate for any leaks, and to deliver volatile anesthetic into the circle system. Then in anesthesia, we need a way of delivering positive pressure breaths or ventilation. And so we add an APL valve to our reservoir bag so that we can generate manual positive pressure breaths using the reservoir bag. And we can add a mechanical automated ventilator to the system as well that can drive positive breaths around the circle system.
Then we need to have an exhaust pipe to allow any excess gases to escape from the system. Otherwise, when we add fresh gas flow to the system, the increased volume being added will result in an increased pressure, and this will be detrimental to the breathing circuit and to the patient themselves. So we have an exhaust scavenging system connected to our circle system.
And there it is, our simplified explanation of the circle breathing system that we use in anesthesia.
I hope that you have enjoyed this introductory video on ventilation for the learning anesthetist. As always, we're open to your comments, suggestions, and feedback via email, and please do tune into the next talk where we cover some of the complications during anesthetic ventilation. Take care.